Today we are going to start the first of what are kind of a couple of grab bag lectures. Okay? And I didn't know what to call them, so I just call them gynecology problems. Okay? And it's split up into vulva, vagina, uterus, and nexa, and then hysterectomies as a category. That's what we're going to be talking about. But each of these has a benign component and then a malignant or cancerous component. So as we go through here, we're going to be talking first about the benign conditions, and then we're going to be talking about the cancerous conditions. Now, one of the things that is up on the website, you remember the vocabulary list you guys had back in anatomy?
Yes.
I made up a vocabulary list here when I first started teaching this class because they had no pictures for anything. Okay, and I think it would be a good idea for you to go through and make sure you know what all of those words mean, okay, what all of those conditions are referring to. And if you have a Mosby's dictionary, many of these conditions have pictures in Mosby's dictionary. Or nowadays, it's very easy to just type it into your web browser and boom, there's a picture, okay? We are going to be looking at some pictures today. But remember, if you don't know what something looks like, okay, or have no clue what it looks like, you know, you're only half educated, even if you know what the words mean, okay? So for you to be at least noddingly familiar with these conditions is kind of what the point is here of this class. So you can take a look at that. All right, now, primary care physicians, family practitioners, and so forth, vulvovaginal problems are among the 10 leading disorders that they deal with. Okay? Now, you probably already guessed that because that includes vaginitis. Okay? We've spent the whole doobie-doo talking about that. Now, remember, with the vulva, you're talking about an area that is pretty much covered with skin, okay, and hair follicles. So you're going to be seeing a lot of things that are similar to what you would see on skin and hair follicles anywhere else on your body. Now, we've already talked about congenital abnormalities and what sort of things can be included in that category. Okay. One thing to remember with the vulva is that with the lack of estrogen during childhood, sometimes the lips of the labia minora will adhere to the lips of the labia majora. Okay? And that's not really usually a problem in little girls. If it becomes of concern or if it's causing a problem, they can prescribe estrogen cream and to rub on the area, and the lips will separate. The lips usually will separate anyway when the little girl starts producing more estrogen as she approaches puberty. Okay, so other benign conditions of the vulva. Okay. Fox-Fortis disease. Fox-Fortis disease. I had never heard of this before I started teaching this class. Which is unfortunate because it's not that uncommon. In fact, when I first started teaching this class, I had a student who came to me and said, "What are these little bumps in my armpits and why can't I get rid of them?" Okay. And I went through the whole doopy-doo. Well, have you tried, at that point she didn't shave, and I said, "Have you tried shaving?" "Well, yes, and they're still there." And I said, "Well, have you tried, you know, deodorant or not wearing deodorant, or, you know, what kind of creams?" And okay. Fox-Fortis disease is similar in some ways to keratosis pilaris. There are keratin plugs that build up in the apocrine glands. Now, keratosis pilaris usually occurs in sometimes the skin of the cheeks on the face, and the extensor surfaces, like the back of the arm. Okay, and it's just little teeny bumps. Okay, and they may be mistaken for zits, but they are not zits. Okay, they are little keratin plugs. Now, keratosis pilaris occurs in just normal sweat glands. Fox-Fortis disease occurs in apocrine glands. So where do you have the most apocrine glands? Okay, in the armpits and in the pubic area. So you may have these little teeny keratin plugged glands. Okay, and they may become inflamed because you got a lot of moisture, you got a lot of bacteria. People may be shaving or waxing or whatever, so there's the potential for inflammation there too. What do you do about them? Not a whole lot. You exfoliate, you make sure that the area stays moisturized, okay? And if there's any inflammation, you deal with the inflammation with antibiotics or whatever needs to be done. Now, another type of cystic structure that can occur in the vulvar skin is a sebaceous cyst or an epidermal inclusion cyst. Now, epidermal inclusion cysts are kind of common, and a lot of times people will not notice that they have them until they notice that there's some sort of little bump in their skin. And then when they start looking closer at the little bump in their skin, they can see that there's an enlarged pore in the skin. And then when they squeeze on the bump, cottage cheesy stuff comes out the pore. Okay. What has happened? You know that the epidermis goes down into sweat glands and it goes down into hair follicles. What happens with an epidermal inclusion cyst is instead of just lining the follicle or lining the pore, the epidermis just continues to grow until it forms a little cave. Okay? And then the secretions from that hair follicle, for example, or that sweat gland, okay, can accumulate in that little cave. Okay? So, is it cancerous? No. Is it normal? No, but it's very, very common. What do you do about it? Usually nothing. Okay, if it's a small one and can be gotten to, and it starts to swell up, you know, the gunk inside it can be squeezed out, and that's the end of the story. They can be excised. Okay, you can cut into the skin and just take them out, and then sew the skin back together at the top. So if they are large or if they are prone to getting inflamed, or infected, you can do that. Okay. Now, you can also have inclusion cysts that involve the mucus glands of the vestibule and the periurethral area. Now, these are going to be a little bit more noticeable, okay? Because when you have little bumps and little bumps that feel like little marbles or little BBs in and around the urethra or in the vestibule, that's something that people are going to notice. Okay? And again, that doesn't necessarily have to have anything done about it at all, okay, but they can be excised. Okay, now, milk line. Have you ever noticed that in puppies and kittens they have, okay, a line of teats? Okay? Sometimes that line of teats will extend down into their inguinal area. Okay. Occasionally, women are born with what are called supernumerary nipples, okay, extra nipples, and they can be anywhere along that quote-unquote milk line. Okay, and that includes down into the groin area. Now, if those little teats or nipples have any associated milk-producing tissue, glandular tissue, they can theoretically make a little bit of milk, which would produce a galactocele. Okay, and You're familiar with galactoseals from the breast. It's an area where you have your glandular breast tissue blocked off, but it's still producing milk, so you get your little cave there filled up with milk. It would be a galactocele.
Would that only happen if it didn't have an exit port?
Yeah. Mm-hmm. Okay. Now, again, you would think that this would be a really wild, weird condition, you know, that nobody would ever see, but I actually had a student in class here 4 or 5 years ago who had supernumerary nipples. Okay, didn't have galactoseals along with them. Okay, vulvar varicosities. Vulvar varicosities are the same kind of varicosities that you have anywhere else. They are swollen up veins. Okay, remember when you find them around the anus, they're called hemorrhoids. We usually think of varicose veins as being something that occurs in the legs, but they can also occur in the perineum and on the vulva. And just like varicosities anywhere else, they tend to get worse with pregnancy. Okay, some of you guys may have seen these already. Okay, urethral caruncles. Urethral caruncles. Urethral caruncles are small, fleshy outgrowths on the edge of the urethra. Now, most of the time when you are looking at the urethra, you see a little divot, a little hole. Okay? Sometimes it appears like a little slit. Okay? A urethral caruncle is when there appears to be tissue that is pooched out from the opening of the urethra. Okay. And that's just a little bit of prolapse of the urethral mucosa. Now, that's not, also, it's not necessarily a problem, okay, especially in children, because they just don't have as much estrogen. When it occurs in postmenopausal women, though, it occurs in the context of a lack of estrogen supporting the tissues. And what we're going to see when we talk about the pelvic floor here in a few weeks is that without estrogen, not only the vaginal tissues atrophy, but the tissues that support the rest of the urinary system atrophy as well. And that can lead to continued urinary tract infections. Okay? So urethral caruncles may be okay, no big deal, or they can be something that is part of a larger problem. Okay, remember that any glands, any sweat glands, any sebaceous glands, any apocrine glands can become inflamed. Adenitis is inflammation of glands. Remember, you have glands in the vestibule that secrete mucus. So vestibular adenitis is inflammation of the glands in the vestibule. This can cause dysmenorrhea, okay, because it's adjacent to the introitus, okay, and it may just be totally uncomfortable for the individual as well. Okay. Now, sometimes the inflammation of these glands is due to an infectious process, and in that case, it would be helped by antibiotics. If it is just a plugged up gland, or it's just an over-secretion of the gland, and it's not an infectious process, then antibiotics aren't going to do anything for it. Okay. Now, how do you deal with tissue growth that is exuberant, or tissue growth that is going nuts, like when you have keratosis pilaris, or you have Fox-Fortis disease, or you have vestibular adenitis? Okay, the way that we do it, which is not perfect, is with steroid creams. Okay? Now remember, steroid creams should not be used on the face ever unless you are specifically told to, and then it should be stopped as soon as possible, because steroids are going to thin tissue. When you thin tissue in the face, you're going to cause sagging and you're going to cause scarring. Okay. So in the perineum, you have the same deal. You have thin skin, especially in the vestibule area here. So if you have to resort to using steroid creams, some of the same considerations apply. Okay, now because the external genitalia are covered with skin, you have some of the same sorts of things that you have everywhere else on the skin. Lentigos. What? Lentigos and nevi. Lentigos are freckles. And nevi are moles. Now, even though those are very professional sounding names, the distinction between a freckle and a mole is not always apparent. And clinically, it doesn't really matter because you're looking for the same sorts of changes with either one. Okay? Skin cancer can and does occur on the vulvar skin. Okay. They particularly worry about melanoma. So moles or nevi, freckles or lentigos on the vulvar skin need to be carefully watched. Okay. I think this particular book says that they need to be removed, okay, straight up. I'm not sure whether all practitioners would go there, especially if somebody has had a freckle for, you know, their whole entire life. But remember, the things with skin cancer, the borders, okay, whether it is asymmetric, whether the borders are smooth or whether they're notched and lacy looking, okay, the color, especially if it has more than one color in it, the diameter, and plus or minus elevation. So when you have especially lesions that are getting a little larger, freckles or moles that are getting larger, okay, they really need to be looked at by somebody who knows what they're looking at. Okay. One of the things that the general population is not aware of, everybody thinks that skin cancer is caused by the sun, and while the sun is involved, it is not the only thing, and there are large proportions of melanomas that occur in other places, especially places that may not have been exposed to the sun, okay? And the perineal area is one of them, okay? So be very suspicious of moles and lentigos in the perineal area, especially when they are changing, okay? Now, fibromas are little benign solid tumors of the connective tissue. Now, when my brother and I were small, we used to laugh at my grandmother. She could not stand it when we fought. And she was always telling us that if we hit each other, we would get cancer. Which didn't make any more sense then than it does now. Okay? But there may have been at least a shred of truth in that somewhere. Okay? Remember, when you damage tissue, the tissue has to recover and grow. Okay? Fibromas are connective tissue tumors. Okay? Now, do they always occur in response to trauma? Of course not. Okay, so Grandma was way off base with that. Okay. Fibromas are not malignant either. Okay, they are localized tissues in the connective tissue. Okay. But they can become gigantic. Okay, they can weigh more than 250 pounds. Okay, which is huge. So they're going to get people's attention. Okay, something the size of a marble or a BB that all of a sudden, you know, eats New York. You know, those kind of things tend to get people's attention. Okay, lipomas are also benign tumors, but guess what tissue they're derived from? Fat tissue, okay? Hydroadenoma are tumors of the apocrine glands, okay? Syringoma is sweat gland tumor, okay? And then neurofibromas are cancers of nerve tissue. Now, are you going to remember absolutely all of those names? Probably not, but the point remains. You can have benign tissues in the genital area that are benign growths in the genital area from multiple different types of tissue. Okay, now female genital mutilation, we talked about that in another context. Remember, female genital mutilation ranges from a simple clitoridectomy, where they basically take off the head of the clitoris. This would be, not the head, the hood, okay, the hood of the clitoris. This would be comparable to taking off the foreskin from the penis, okay, but again, the hood of the clitoris is very tiny, okay. You can sort of make a case that philosophically that's the same procedure that the men undergo. The female genital mutilation, though, that gets the press, okay, is when you basically have excision of the clitoris and the labia minora, okay, excision of the clitoris and the labia minora. Now, if it's not obvious to you that that's going to cause spectacular problems, then I have totally failed as an anatomy and physiology teacher. Okay, you've got not only the vagina there, you've got the urethra there. This stuff can scar back together. It presents a spectacular infection risk. It screws up sexual function. It can make vaginal delivery either impossible or can cause people to tear spectacularly during a vaginal delivery, okay? So it's a really bad deal, okay? And there's a huge push going on by the United Nations, for one, to get rid of female genital mutilation, okay? Okay, and again, obstetric lacerations, episiotomies, tears, those kinds of things are things that are pertinent to note. Okay. Just briefly, you guys are probably aware, but I don't want to omit it. There's debate about episiotomies back and forth. They tend to go in style and then out of style. Okay. The idea is that it is easier to deliver the child with less trauma to the perineum, okay, and that gets debated, okay. And then the idea of where you cut an episiotomy, whether you cut it midline, which would risk involving the central tendon and the perineal body and the anal ring, or whether you cut it oblique, okay. The oblique angle is going to require you to sew the transverse perineus muscle back together. The fibers are going like this, okay, and you've cut across them at an angle, okay, so having to sew those fibers back together at an angle. So that's why you have debates. It's easier to sew back together in the midline, but then if your structures don't heal properly, your whole pelvic floor has issues. Okay, so that's why there's a debate among surgeons about the best way to do it. Now, you already know that there are some situations where an episiotomy just isn't optional. You got to get that kid out right now, and you just try not to tear the perineum up too much while you do it. Okay, for example, a prolapsed cord. Okay, squamous cell hyperplasia. Squamous cell hyperplasia is a local thickening of the epithelium. remember, any tissue that you irritate will change. Any tissue that you irritate will change. So, for example, if there's an allergic reaction, if there's a rheumatoid disorder, if there's a bug infestation, if there's a nervous disorder, okay, the nerves are causing itching when there's no reason to be itching. Okay, those things can cause scratching of the perineum, and that scratching can lead to squamous cell hypoplasia, okay, which would be a leathery sort of raised surface. And again, they try to stop the itching if itching is causing it. They may use steroids for it. A little more problematic thickening is lichen sclerosis. Lichen sclerosis can cause intense itching, it can cause dyspareunia, it can cause burning pain, and it usually occurs in menopausal women. The skin can be thickened and it will eventually develop a thinned tissue paper, crinkly appearance. Okay. Now, part of this is from the lack of estrogen. And part of it appears to be an inflammatory condition. I don't think they have a specific etiology for why it happens. Okay. Again, they usually use topical steroids. Okay. But aside from the discomfort, it's something that needs to be addressed, because if it progresses, it can destroy the architecture of the skin in that area. It can constrict and destroy the normal genital architecture.
And what was that part of it?
Lichen sclerosis. Lichen sclerosis tends to be more whitish. Okay. I have some pictures here in a minute of this. Lichen planus, on the other hand, tends to be a thickened purplish area. And lichen planus also may erode, okay? And it may have lesions that occur inside the vagina and also inside the mouth as well. Lichen planus is also an inflammatory disorder. Okay, so with both lichen planus and lichen sclerosis, you're probably going to be referring to a dermatologist or perhaps a rheumatologist. Now, psoriasis is a velvety or scaly patch. Okay? Often psoriasis occurs on the knees and the elbows, but it can occur on the face, on the head, and it can occur on the perineum. Psoriasis is an inflammatory disorder. It's an autoimmune disorder. It's often associated with arthritis. So again, psoriasis is something that needs to be referred to a dermatologist, if not a rheumatologist. Okay. Eczema, you remember, eczema is a garbage term for inflammatory reaction. Okay. So usually you think of eczema as being an allergic reaction to something. Often it can be a pain in the butt to track down what it is that the person's reacting to. Okay. Now, Behçet's syndrome. Behçet's syndrome. This also involves ulcerations in the genital and oral area. When we talk about ulcerations, we're talking about things that are similar to canker sores. But in this case, with Behçet's syndrome, these lesions persist, and over time they can cause scarring. They actually appear to eat into tissues, so they not only can scar the vulva, they can produce fenestrations or holes in the vulva. Now, all of these autoimmune, inflammatory, kind of conditions they tend to go in groups, and they tend to go along with each other. So, for example, you can have vulvar or ulcers that are associated with Crohn's disease, which is usually thought of as being a gastrointestinal disease. Okay, decubitus ulcers. Do you know what a decubitus ulcer is? A decubitus ulcer is something that results from pressure between the skin and a bony part, usually. So bedridden women would get decubitus ulcers. With that, you have breakdown in the circulation of that area of the skin, and the skin dies. Okay, acanthosis nigricans. Acanthosis nigricans. This one you have probably seen and not known that you saw it. Acanthosis nigricans. Okay, it's commonly found in the intertriginous area. Where you have two adjacent areas of skin that potentially can rub on each other. So, you would have an intertriginous area here, okay, in the crotch. You would have an intertriginous area underneath the breasts. You would have an intertriginous area in the axilla. Okay. So, acanthosis nigricans is most commonly found in the intertriginous area, usually in the axilla, and it also may be found on the nape of the neck. Okay. And there are darkly pigmented, velvety, or sometimes warty little lesions. Now, have you ever seen somebody who had a bunch of little dark brown or black spots across here? Okay, and they kind of were velvety looking? Okay, that's acanthosis nigricans. Okay. Now, why do you even care? You care because it can be related to insulin resistance, and it can be related to malignancies, occult malignancies. Now, occult malignancies are not malignancies that worship the devil. Okay. Occult malignancies are ones that have not revealed themselves yet. Okay, so it can, people who have acanthosis nigricans need to be watched for the development of diabetes, and their screening for cancer needs to be thorough. Okay.
And so it's not just dark skin, it's like dark little
Patches. Yeah, I got some pictures here in just a second. Okay, last one, intertrigo. Intertrigo is an inflammation in the intertriginous areas. So you may have seen women who are very heavy and have very pendulous breasts, and they have a bunch of irritation under their breast. Okay, that's intertrigo. Now, the intertrigo is a couple of things. It's the irritation caused by the skin rubbing, okay, rubbing on the adjacent skin, but that irritated skin can also become infected. So you can have a staph infection accompanying intertrigo. You can have a candida infection accompanying intertrigo. All right, so let's look at some pictures here. Well, actually, before we do, one more thing. Vulvodynia. Vulvodynia. Vulvodynia is pain in the vulvar area with no apparent cause. Okay, no obvious pathology. Does that mean that you get to ignore it? No. Okay. You have to look for the development of lichen sclerosus, lichen planus. It can be the result of a herpes infection, okay, vulvodynia, just like with shingles and with the other types of herpetic infections, where sometimes you have lesions, sometimes you just have pain, neuralgia. Okay, it's thought that with vulvodynia, occasionally a herpes infection will be causing it. So, chronic vulvar discomfort or pain. All right, pictures. Okay, intertrigo. Okay. Now that looks to me like it's infected with probably staph. Okay, that's an underarm, that's an axilla. This is intertrigo under a breast. Okay. Now with satellite lesions like that, you would be suspecting that this is infected with Candida. Okay, it looks a lot like diaper rash. Okay, again, intertrigo. Okay, what do about it? They separate the skin surfaces and try to keep them dry. Okay, sometimes that works well, sometimes it doesn't. With bedridden individuals, they try powders and all kinds of stuff. Here's intertrigo in the groin. Okay. My guess is that they probably have belly fat hanging down here, and that for the picture they've shoved the belly fat out of the way. It's a crummy picture. Hydradenitis suppurativa. That's an axilla. Hydradenitis suppurativa is a infection of the apocrine glands. And so you can see these dark red patches here where apocrine glands are infected. The difference between hydradenitis suppurativa and Fox Fortis disease is that Fox Fortis disease is not an infection primarily. Okay, here you have an infected apocrine gland. It looks like in the groin. Okay. Here you have what looks like scarring in the axilla. So hydradenitis suppurativa can lead to scarred tissue. Fox Fortis disease, on the other hand, usually doesn't. It's usually a bunch of these little bumps. They look a lot like milia, but they're not. Okay, milia has the stuff is different, and this is a keratin plug. Okay, so if they try to squeeze the gook out of these, okay, usually that doesn't work. Usually it just, there's no gook to come out. It's a buildup of keratin around the little pore. Okay, so exfoliation, okay, and convincing that skin not to overgrow around the pore is what you do. You don't squeeze the gook out. Okay, Behçet's disease. Behçet's disease is the one where you have ulcers. Okay. Now, canker sores are sometimes called aphthous ulcers. Ulcers. There are a lot of people who get canker sores when they get stressed out. Okay, that's a different, as far as we know, a different deal than things like Behçet's disease, Crohn's disease. Okay, Behçet's disease, Crohn's disease these you can have ulcers in multiple different places, and they have an inflammatory autoimmune cause. Okay, lichen sclerosis. Initially, you may have thickened skin. Eventually, the skin will become thinned. Okay. Again, you have an inflammatory process going on. It may be autoimmune. Okay. The treatment is usually steroid creams. Now, the problem is you have your epithelium, your epithelial tissue growing in a way that it shouldn't. So they usually biopsy these lesions to make sure that they aren't dealing with squamous cell carcinoma, for example. Okay? So they rule out cancer before they start dumping steroids on something like this. Okay? But it can be extensive and it can scar the vulva. Okay? Here you have smaller lesions. Actually, the way this picture is, this area is probably what the lesion that they're talking about. Right, what's that? Yeah, it's a sebaceous cyst behind the ear. Okay. Now you can have sebaceous cysts like that wherever you have sebaceous glands. Sebaceous glands are associated with hair follicles. So you could have sebaceous cysts in the groin area. An inclusion cyst may look just exactly like that. But an inclusion cyst may not be associated with a sebaceous gland. It may be associated with another type of skin structure.
What do you do for this?
Nothing. Okay. If they're infected, you give them antibiotics. If they become infected and you need to incise them and drain them. Sometimes if there's an opening, you can squeeze the goop out of them. Sometimes they'll go away after that. With inclusion cysts, if they become a problem and continue to be a problem, you excise them. Okay. With sebaceous cysts, again, you can incise them, cut them out.
There it is. YouTube videos. I love it. It's so gross. Yeah, if you're curious, there's an entire genre of YouTube videos of people just popping cysts.
Oh, it's not, it's gross.
It's intense.
Sounds gross. Very gross.
People are gross.
Okay, here you have a cyst in the vulvar mucosa, and what it's doing, or what they're doing, is they are incising the skin, and then they are incising the cyst wall. Now, by location here, this looks an awful lot like a Bartholin cyst, and it's probably what they're, it's not labeled that way, but any other type of cyst you could do the same sort of thing with. Okay, psoriasis. Yeah. Okay, you can see the reddened area there. All right, acanthosis nigricans. Acanthosis nigricans can be dark spots, or it can be sort of a generalized darkening of the skin in that area. So here what you're seeing is a generalized darkening of the skin, and then this is, I don't know, it's probably the axilla. Okay, see that? Now if you think about it, you've seen this, because there are people out there, especially dark-skinned people, that have patches of their skin that are darker. Okay, may or may not be acanthosis nigricans, but often is. Okay, so with your dark-skinned women, this is something to look for. This is the acanthosis nigricans, not that. That's a freckle or a lentigo.
Can that happen in kids?
Yeah. Okay. See how this axilla is way dark?
Yeah.
Okay.
They don't do the patches if it's more like the last slide that we just saw. You and we're screening them for diabetes. I mean, is there really anything else we should do?
diabetes and sometimes occult malignancies.
Okay.
Occult means that it hasn't revealed itself yet, so
Just recommended.
their cancer screening needs to be, not neglected.
Okay, and that would be referring them to a dermatologist.
Not necessarily if they have no symptoms for it,
Okay,
okay,
just
but,
education then on.
right.
Okay.
So, for example, their pap smears, their breast exams, their, colonoscopies, okay, all of that kind of stuff needs to be maintained. Okay, that's acanthosis nigricans. See how here you've got darkened area of the skin, but you also have these little, almost warty-like little dark projections from the skin. Okay.
What is that? What are we looking at?
An elbow or a knee? Yeah, one of them.
I've never seen it that bad before. I've definitely seen it before and never saw anything of it.
I'm not sure in this case. It might
It's
be-
actually an elephant.
It
trunk.
might be an accident. It might be an accident, I'm not sure.
Okay. I can't tell.
Mm.
Oh, wow.
Okay.
Maybe it's the same guy
itchy
reference.
or?
Not necessarily. Okay, so people may think, okay, that's just the way my skin grows. Okay, again, dark-skinned people. Right. Okay, let's take a quick break and then we'll come back and do vulvar and vaginal stuff real quickly. Benign conditions of the vagina. We've already talked about the congenital abnormalities of the vagina. We've already talked about how DES exposure can cause specific types of abnormalities in the vagina. You can have inclusion cysts in the vagina, just like you can in other parts of the skin. It's stratified squamous epithelium in there, okay? You can have Bartholin cysts, okay, in the perineal area. What do you have to rule out with Bartholin cysts? Gonorrhea. Are Bartholin cysts always caused by gonorrhea? No, but it's common enough that you have to rule it out, okay? You can have endometriosis in the perineal area. Weird as that seems. Okay. And then we're going to be talking about cystoceles and rectoceles and all that business in another lecture. Okay. Vulvar and vaginal cancer. Now, as you would expect, because we're talking about skin or stratified squamous epithelium in both cases, both vulvar and vaginal, you would see cancers that are similar to what you see in the skin in both areas. So you have basal cell carcinoma, you have squamous cell carcinoma, and you have melanoma. Okay? Now, malignant tumors of the vulva are uncommon. Most of the time, they are squamous cell carcinomas. Okay. And I want you to know that the number one tip-off, okay, is chronic vulvar itching. Chronic vulvar itching. Now, we saw this with lichen planus and lichen sclerosus and squamous cell hyperplasia. Okay? Just because it itches doesn't mean that it's just, annoying. It may be an indication of something more serious. Now, vulvar cancer is associated with human papillomavirus infection and with smoking. And it can be associated with other types of STDs as well: syphilis, lymphogranuloma venereum, and granuloma inguinale. Now, Bowen's disease and Paget's disease. You may hear Bowen's disease or Paget's disease. Those are older names for specific types of vulvar cancer. Okay. You can have vulvar cancer without an obvious lesion. Okay, so when somebody has itching and they can't figure out what it is, you know, just telling them, here's a can of steroid and sending them home is probably not the wisest thing. They probably need a biopsy before they just, you know, write it off and just give them steroids for it. Okay?
What was the other disease? Paget disease and
Bowen's disease.
So there Paget's disease and breast.
Yes, and there's also a Paget's disease in bone.
Mm-hmm.
Okay, which is why we trying to get rid of some of those names. Okay, now squamous cell carcinoma accounts for about 90% of vulvar cancers. Again, itching, lumps, bumps. Vulvar cancer can spread through the adjacent lymph nodes. It can also spread via the blood. It can metastasize to distant areas. Okay. Book says that any pigmented lesion on the vulva requires excisional biopsy for histological diagnosis. That's a pretty flat statement. The reason for this is that melanomas tend to metastasize even earlier when they are found on the vulva than when anywhere else. Okay? And melanomas often metastasize before they're big enough to worry about. And melanomas often have a spectacularly nasty prognosis. Okay. So some pictures. And that's vulvar cancer. The reason you would know that that's not a chancre is because you have necrotic tissue in here. Okay. Okay. It's not a very good picture, but what they're showing you is what they do with a partial vulvectomy and what they do with a radical vulvectomy, okay? Which is similar in some respects to genital mutilation. Okay, you can have vaginal neoplasms. Carcinoma of the vagina tends to be asymptomatic. And it also appears to be related to infection with HPV. You also need to be suspicious when you have abnormal vaginal bleeding, vaginal discharge, or urinary symptoms. So if you have abnormal vaginal bleeding, vaginal discharge, urinary symptoms, and you've ruled out infections, you've ruled out STDs, you've ruled out urinary tract infections, okay, you've ruled out endometrial problems, okay, then you need to be looking whether you have carcinoma of the walls of the vagina itself. Now, again, are you going to see these if you don't turn that speculum? Okay, so when I hear people say, you put that speculum in straight and you don't move it. Okay? Well, okay, you need to put that thing in there and make sure you're not pinching tissue, okay, which means being careful, okay, but you're not seeing everything you should unless you turn that thing, okay. Now, some of these things are more rare and you may not have a reason to go looking for them, but if you do have a reason to go looking for them, you're not going to see it unless you turn that speculum.
I have a question.
Yes, ma'am.
With the itching and all, is that something that would probably not respond to any treatments? Like you would culture it and there wouldn't be any sort of bacteria there.
No, not you wouldn't culture it. You biopsy it.
Right, I know, but I'm saying when you're ruling out, they just have persistent itching. Like
They would
your
biopsy it.
thing.
They would biopsy it. A dermatologist. That's what, you know, if you go for a dermatologist for just about anything, even when they have a pretty good idea what it is, they'll biopsy it.
Right, but they're coming to us and they're only
Okay.
So we're gonna rule out candida, we're gonna rule out, you
Yes.
know, all of the things that would cause vaginal itching.
Right.
So if they're treating it at home with monostat,
And it's not working.
it's not gonna respond to any of the typical treatments, it would still persist through the treatment.
Correct.
Okay.
Okay, so if you painted it with gentian violet, for example, okay, it's still gonna persist. Okay? Yes, now I understand what you're saying, yes.
Would we recommend to go to a gynecologist for that, or a dermatologist?
If it is just on the vagina, just on the vulva, I would send them to a dermatologist first. You know, you could go either way, but if a gynecologist doesn't know what it is, he's gonna send them to a dermatologist for a biopsy. Okay, and they're gonna look under the microscope at the actual tissue structure, and then they're gonna say it's either this or it's that. Okay. All right, the uterus and the cervix. Okay, we've already talked about structural stuff. Okay, and guys, what's the difference between a bicornate uterus and a septate uterus?
One goes all the way down.
Okay.
And they got marked off the diagram, I don't know why.
Okay, I forgot. Joanne's in here, so just forget to talk about that later. Go back and look at the pictures. All right. Uterine fibroids. Are the most common benign issue with the uterine wall. Okay. I'm not sure that they are. Let's see what it says. Okay, fibroids, the real name of a fibroid is a leiomyoma. And that's because they are abnormal growths of the muscle cells of the myometrium. Leiomyoma is a fibroid. Derived from the smooth muscle cells of the myometrium. And it's the most common neoplasm of the uterus itself. Now, fibroids can cause excessive uterine bleeding. And if you think about that, if you have endometrium that just lines this, you have a certain amount of endometrium. But if you have endometrium that has to line all that, you have more endometrium, correct? More surface area. Okay. If you have more surface area and you have more endometrium, you're going to have more bleeding with periods. Okay. Also, if you have stuff in the walls here, is the wall going to contract as effectively? No, that also is not going to shut off the bleeding as effectively. Okay? So, fibroids can cause excessive uterine bleeding, pelvic pressure and pain, as well as infertility. Usually fibroids are more of a pain in the butt than life-threatening. They don't usually turn malignant. The risk factors for developing fibroids, increasing age, ethnicity. African American women have a 2 to 3-fold increase compared to Caucasian women. Women who have never had any children have a higher risk. And then also family history. And higher body mass index. it's known that the sex steroids from the ovaries enhance the growth of fibroids. Sometimes fibroids can grow to be enormous during pregnancy. And that's a huge problem because then it can interfere with developing an effective labor pattern, contraction pattern. Now, sometimes these tumors grow so big that they outgrow their blood supply, and when they do, areas within the tumor will die. That can result in further weakening the uterine wall. So, depending on where your fibroid is and how big it is, okay, pregnancy and delivery can be an iffy kind of situation. Now, some of the places that you can have fibroids, intramural means that it's within the wall. Okay. Interstitial would be the same thing. If it's more towards the outside, it would be considered a subserosal, underneath the serosa. If it's more towards the endometrium, it would be called a submucosal. If it's sticking out on a stalk, it would be called pedicled. And you can have pedicled ones that are sticking into the uterine cavity. You can have pedicled ones that are sticking out into the peritoneal cavity. You can also have fibroids that actually detach themselves, okay, and those are called wandering fibroids, or wandering or parasitic fibroids. Now, the majority of uterine fibroids cause no symptoms. They can be palpated sometimes on by manual exam, especially the subserosal ones. They're going to turn up on ultrasounds, especially if they stick into the uterine cavity. The lady may have no symptoms at all, or she may have dysfunctional uterine bleeding. She may have pelvic pressure, congestion, bloating, a feeling of heaviness in the lower abdomen or the lower back. Now, that constellation of symptoms right there, you need to have in your mind, because those are also the symptoms of ovarian cancer. Okay, we're not going to be talking ovarian cancer until a different lecture, but the symptoms of fibroids are almost identical to the symptoms of ovarian cancer. Fibroids, again, we said, are just an annoyance compared to cancer.
Can you go over the symptoms one more time?
Dysfunctional bleeding, which may or may not be associated with ovarian cancer. Pelvic pressure, congestion, bloating, a feeling of heaviness in the lower abdomen, and lower back pain. Now, if you have degeneration, if this outstrips its blood supply and degenerates, you may have a great deal of pain. Okay. And again, depending on where the fibroid is, you may also have dysmenorrhea. It should be obvious why these could be associated with infertility. You can have disruption enough in the endometrium here to, impede proper implantation, a proper traveling of the sperm up through into the tubes. Okay, now if you have a mass in the uterus and it moves when you move the cervix, okay, you are more likely to be feeling a fibroid, especially if you don't have cervical motion tenderness along with it. tumors are usually non-tender, they usually don't produce cervical motion tenderness, but when you move the cervix, okay, the uterine mass moves with it. Now remember, they are sensitive to hormones, so the way that you treat it is by shutting off the hormones. And there are various ways to do that. Okay, you can shut off hormones with birth control pills. You can shut off hormones with agonists at the hypothalamic axis. You can cut the tumor out, which is called a myomectomy. However, this is not a preferred way of dealing with it for a couple of reasons. Number one, you have to go in, it's abdominal surgery. You have to go in through the peritoneum. Also, when you cut on the uterus, then you usually are starting to have to consider C-sections then if the person becomes pregnant after that, especially when you're not dealing with the lower uterine segment here, but when you're cutting up here. Okay. So in an effort to preserve fertility, they have looked for other ways besides just a myomectomy or a hysterectomy in somebody who wants to just be done with the whole thing. Okay. Embolization means that you go in through the uterine arteries, okay, and you run a catheter down to where the fibroid is. This has to be done under either ultrasound or fluoroscopy. Okay. And then you put an embolizing agent in the blood supply there to that little fibroid. That will cause that fibroid to die. Now, you can do this in outpatient surgery, but one thing that needs to be considered here, okay, if you kill off a chunk of tissue in the uterus, what is that going to result in for the patient? Severe pain. Okay, so even though this can be done in a same-day surgery setting, they may need to have some fairly serious narcotics afterwards because it can be excruciatingly painful, and that alone may, mitigate towards admitting the individual. Okay. Also, depending on where it is and what goes down, you can have severe bleeding. Okay. So sometimes people assume that same-day surgery is, like getting your lunch at McDonald's and there's no big deal. Okay. It can be depending on what you did. So embolization in the uterine arteries. All right, we talked already about the cervical cancer. Okay, we're going to talk about endometrial cancer in a great deal of detail down the road. Okay, so let's talk about uterine corpus cancer. Actually, we're going to talk about it right now. Okay. All right, cancer of the endometrium is the most common gynecological malignancy in the U.S. So, and I can never keep this straight. Whether it's cervical cancer, breast cancer, or endometrial cancer. Okay? And I'm highly suspicious that it depends on who you talk to. The take-home point for you, okay, if you want to make sure that women don't die from stuff, okay, you need to be vigilant for breast cancer, cervical cancer, and endometrial cancer. Even though uterine fibroids are an abnormal growth, they usually do not become malignant, and so therefore they usually don't kill people. endometrial cancer, the risk factors being affluent, obese, postmenopausal, and having few kids. Affluent, obese, postmenopausal, and low parity. Now, those risk factors make sense when you know that any factor that increases unopposed estrogen. Okay. Remember, estrogen causes the endometrium to grow. Progesterone causes the endometrium to develop properly and then slough properly in the last half of the cycle. So if you just have estrogen, this tissue is just going to grow, okay? It's not going to finish its development and then slough properly. So most of the situations here, low parity, okay? They've had more stimulation of the endometrium, okay, because they haven't been having breaks of being pregnant. Postmenopausal, they've been exposed for a long time. Okay, they no longer have progesterone in the picture so much. Affluent and obese, those kind of tend to go together sometimes. Obesity, remember, adipose tissue produces estrogen. Okay? So unopposed estrogen is a huge risk factor for endometrial cancer. Okay, unopposed estrogen causes endometrial hyperplasia. In other words, you get a much thicker endometrium. Okay, now some of the treatments for breast cancer also can increase endometrial cancer. So another thing to keep in mind is that breast cancer, ovarian cancer, and endometrial cancer tend to be related. And what you do for one may make one of the others worse. All right, there's no simple way to screen for endometrial cancer. Okay, primarily it's done with the pap smear. You can also look at the endometrium with an ultrasound and you can measure how thick it is. Now, one of the things that you're looking for with dysfunctional uterine bleeding is a thick endometrium, okay, because that's what's bleeding out. Okay, so when you have heavy bleeding, the first thing you look at is what is the endometrium doing? Okay, and then you look at why is it doing it? So the most common symptom of endometrial cancer is abnormal vaginal bleeding, and especially if a person is postmenopausal. Now, menopause means that you have ceased having periods, and that's for at least a year. The perimenopausal period, okay, people will miss periods sometimes for several months at a time, okay, and then they'll have this huge long period where they bleed like crazy because they've got that thickened endometrium. Okay, so the perimenopausal period, you have a lot of crazy stuff going on. You tend to have more dysfunctional uterine bleeding around perimenopause. Okay. After menopause, once you no longer have follicles and you no longer have progesterone, you shouldn't have any reason to have a thick endometrium. Therefore, postmenopausal bleeding is always suspicious. Postmenopausal bleeding, the very first thing you look for is endometrial cancer. It's always abnormal. chapter on uterine cancer, I want you to notice that what they do is big guns right from the get-go with endometrial cancer. Okay, just like with cervical cancer, it's like you go from, okay, this is still in the epithelium, to hysterectomy, okay, with chemotherapy and radiation. Same deal here. Okay, here we go from total abdominal hysterectomy and bilateral salpingo-oophorectomy. In other words, they take everything out, and that's for stage 1. Okay, so for stage 1 endometrial cancer, they take everything out. Okay, and then they may use radiation therapy or potentially chemotherapy. Okay. Now, the prognosis depends on what type of screw up your endometrium has accomplished, depending on how screwed up the cells are. There are some types of endometrial carcinoma that have a really, really bad prognosis, which is why they start with take everything out, okay, as their first step. Okay. Okay, now a leiomyosarcoma. Now, what's the real name of fibroid? A leiomyoma. If I told you that sarco or sarcoma is the name that they give to connective tissue and muscle cancers, connective tissue and muscle cancers, a leiomyosarcoma would be what? It would be that thing that turned malignant. Okay, now we said that usually fibroids don't turn malignant, but in a small percentage of cases they can turn malignant, and that's called malignant transformation. And again, you have exactly the same symptoms that you have with a fibroid: pelvic pain, abnormal uterine bleeding, pelvic or lower abdominal mass, okay, discomfort, bloating. Now, if you have a known fibroid and then the picture changes, like it appears to be rapidly enlarging, or especially after menopause. After menopause, you've shut off the hormone influence, so the thing should be going away, getting smaller. Okay? So a known fibroid that's rapidly enlarging and the person's not pregnant, okay? Or all of a sudden the bleeding patterns change. You know, you may have heavy periods sort of as a normal thing because you have this fibroid, but all of a sudden your bleeding pattern really changes. Now, the prognosis for this is usually pretty good, but again, the only way to really fix it is to take the thing out. Okay, and again, they usually just go to a total abdominal hysterectomy and bilateral salpingo-oophorectomy. And the reason for that is if it's malignant, so let's just not screw around. Okay? And in this case, it's easier to just take out the whole thing. Okay, now the problem with leiomyosarcomas, okay, is that they tend to spread through the blood, and so sometimes when they are caught, they have already spread. So again, the prognosis tends to be poor. The good news is that most uterine fibroids don't transform. Okay, so both types of uterine malignancies, endometrial cancer and leiomyosarcoma, both of them have poor prognoses. Endometrial cancer is the worst one. It's the more common one. Fibroids usually don't transform, but when they do, the prognosis tends to be kind of poor. With either one, the definitive treatment is an early total abdominal hysterectomy. Now, you can see why OBGYNs being trained as surgeons, why when somebody hits perimenopause and they have dysfunctional uterine bleeding, why, from their perspective, they're like, let's just take the thing out and be done with it, okay? Then you don't have dysfunctional uterine bleeding anymore, and I don't have to worry about whether you're developing endometrial cancer or whether you have uterine cancer, okay? Now, I had a family member who had spectacular dysfunctional uterine bleeding in the perimenopausal period, and her OBGYN, being a logical, rational person, was like, let's just do a hysterectomy. Okay? She didn't want to have a hysterectomy, and it made her family really mad. In fact, she had a son that threatened to shoot the doctor. Just stupid, okay? That was a perfectly reasonable medical suggestion, okay? Nobody was trying to maim his mother, okay? Now, there are some women, though, who feel as if they have been maimed if they have body parts taken out. Okay? And so there is a spectrum of thought that you are somehow maiming the woman and she's not going to enjoy sex because she's not going to have the uterus to contract and all this, okay? It may not be much ado about nothing, okay, but it's a little bit of overkill, okay? Can women have an orgasm after they've had a hysterectomy? Yes, okay. Some women never even notice the difference, okay? If it is going to really spectacularly affect her body image, is that a medical issue or a psychological issue? That's a psychological issue, not a medical issue. Okay? Now, are psychological issues legitimate? Of course. Okay. Maybe people who just, you know, they look at the odds, they look at the chances of different things, and they go, no, this is just dysfunctional uterine bleeding. There are other ways to deal with it. For example, they can go in and they can ablate, they can take a laser and burn all of the endometrium off, which will produce Asherman syndrome. Will that individual bleed? No, okay? And that also, if they do it right, should remove the chance that they'll have endometrial cancer, hopefully, okay? Does it remove the chance that they'll have fibroids? Okay, no. Are they still going to have to pay attention to what's going on with their uterus? Mm-hmm. Yes. Are they still going to have to worry about cervical cancer? Yes. Yes, okay? So from the physician's point of view, they're sitting here going, okay, you know, we could just solve a whole lot of problems here, let's take it out. Okay. So you see how the decision-making process goes? There was a real thing, it may not be so much of a thing now, but back when women were running around burning their bras, there was this big thing about hysterectomies, okay, that hysterectomies were imposed on women by male doctors, you know, all this, you know, hysterical stuff. It's like, get a grip, people. Okay, there's all kinds of reasons for doing hysterectomies, and you know, there's all kinds of other things that can be done too. All right, any questions? Okay. Yeah, I think so. I can't remember. Deb, sorry, you got here right at the time we're done. Okay. Joanne, you need to take the